The question is injury prevention. No question mark. It's a statement, injury prevention. But we want to touch on it because, number one, this is probably the last time as I address this question that I'm going to even say the word prevention. I'm going to take the words out of your guys' mouth. I know you're going to say it, but
damn you.
I know you can repeat it because it's that important. We can't really prevent anything. There's too many factors in injury, in pain, in performance to account for to truly do that. I mean, you could have the most gifted athlete who's the most prepared as they could possibly be, and if somebody with a helmet runs into their kneecap and they blow their knee out, there's just no way to account for that. So injury prevention is kind of a farce, but what we can do is try to reduce the risk as best we can, injury risk reduction. So this is a very general question or statement, so the answers are going to be pretty darn general, but let's talk about some non-modifiable risk factors. We know one of the main ones is previous injury. So I always joke around with my athletes is if you really wanted to prevent your injury, you wouldn't have gotten hurt in the first place, because we know it's a pretty strong predictor of future injury is past injury. And we don't really know why that is. Maybe maybe the tissues never fully heal, no matter what. There's always kind of like a little bit micro scarring there or something that they are not quite the same. Or maybe there's some type of cortical mapping that goes on where you just can't quite use that limb. The connections aren't quite the same as they used to be. Or maybe a combination. Maybe it's the fact that nobody really rehabs appropriately. They don't take enough time to truly progress slowly and step by step by step. And most likely it's a combination of all of those factors. As we get older, injury risk seems to climb a little bit. If we spike our training loads in either direction, which is probably the biggest modifiable risk factor, which we've talked about in previous episodes and we'll continue to talk about, is managing our training load, but trying to reduce the concentrated spikes in our training, like, hey, I didn't do anything all summer, but oh shit, it's preseason, gotta go. You jump right into 2-a-days or 3-a-days or whatever, and that's where you see those injury rates spike. And it works the other way. When you don't do anything, you become deconditioned. So if you get hurt once, man, that sucks. But if you want to try to reduce the risk of recurrence, don't do nothing. Because if you do nothing, you are becoming more susceptible to recurrence because you're deconditioning. You're becoming less fit, even less fit than you were. So we've hopefully talked and we'll continue to talk about ways to modify your training so that you don't get in Mother Nature's way, but you also mitigate deconditioning is really, really important. So as far as I'm concerned, I think that training load management is probably the best bang for your buck concept in regards to injury risk reduction. Now, if we talk about specific cohorts like quad index for return to play, with ACL, quad index being strength symmetry from affected to unaffected sides. It used to be, I think when I was in school, 80% quad index was still kind of an accepted thing. It was like if you can get the surgical limb to 80% quad strength as the other side, yeah, you're pretty good. If you get that in that 4 or 5 month mark and the surgeon's like, hey, you're clear to play, we'll get back out there. And, now it's like, gosh, that is the bare minimum. 85, 90%, somewhere in that realm is now looking like where we need to be. And, even then re-tear rates are pretty darn high. I think it's like 27% or something like that. So, we don't have many other like cohort specific risk factors, and we just don't quite have that data. And you guys can speak on that if you can think of something that pops into your head. But I think for me it's really just about looking at their past workload, how they responded to it, and then tailoring the future program based on that. So if somebody gets hurt, I look at the program that they were running leading up to that point, and I say, well, obviously you weren't dealing with that very well. And so what if we take that exact program, but maybe we chop a little bit off the top end as far as intensity, or we spread it out over the course of a few more weeks, maybe an entire block, so you end up getting to the same spot, but it's just a little bit more graded approach to get there. I'll stop there. What do you guys think about injury prevention?
I think if you are going to prevent something, then it seems like you can predict it, and we suck at that too. I used the FMS for years. I really did. And I threw it out a few years ago once I did a couple thousand tests on people over and over and over and realized that this isn't giving me really any answers. And then you look at the research coming back from it, it's not very compelling. We're just not very good at being able to look at somebody and a small snapshot of how they move in a clinic or in a controlled environment and say, you are or are not going to get hurt. And that's had a bit of a nocebo effect on people for a long time as well, which is a whole nother discussion. Mm-hmm. But I'll just echo the one thing that I've found, and it's a risk reduction thing. I'm going to say the exact same thing that Quinn said, is that you have to be prepared all the time. That doesn't mean that you have to be going squat every day and go to maximum all the time and all that kind of stuff. But you have to have a legitimate planned training program to make sure you're ready all the time. And that way, it at least puts you in the best position to keep those training spikes low and to continue to move and take small steps forward. Jared, what do you think?
No surprise, I agree with both of you. And I think another piece that came up a bit when Quinn, you and I were talking to Steph Allen, is the psychological component. We know that one of the biggest predictors of re-tear rates for ACLs is fear of re-injury, right? And I'm sure that I'd wager that's probably would probably be a consistent finding if we looked at other types of injuries as well. So I think for us as clinicians and for people who, or just for people in general, even if they're dealing with an injury themselves, I think it's important to understand what we're talking about here and now, in that we suck at predicting injury. We can't prevent it fully. We'll never be able to do that. We can reduce the risk primarily by changing or by managing what we can change, those modifiable risk factors. And then that doesn't need to be, I don't think, a really negative thing. I don't think someone needs to say like, oh shit, I'm doomed. I have a higher risk of being injured now because I've been injured once. I get that as a knee-jerk reaction because I've swung through multiple phases of that myself. But I think what it means is, or what it should mean, is that now we've got a better, less skewed picture of what we're working with right now. Wishing it was different doesn't mean jack, because it's not. You can only change what you can change right now moving forward. So let's plan for an appropriate period of time to do what we need to do. And what do we need to do? Well, that's based on what the research is and what we've just talked about here. So what do you want to get back to? Where are you now? How are we going to know when we're there? Or how are we going to know that we're making progress? So whether that's something like quad index, or whether that's something like range of motion, or whether it's something like controlling dynamic valgus as you're doing some sort of cutting or jumping, being able to map that out and to make peace with the fact that it probably is going to take a lot longer than we'd like. If we're the person that's going through that, I think that's probably a universal finding or near universal finding, where it just drags on and on. And we think that, we should be better sooner than we actually are. I think some of that can be mitigated with this upfront conversation, that we're having with our patients, or that, someone who's injured could have with a reputable healthcare provider to help them guide them through that process. Because if we know that, okay, I'm in for at least a year or 9-10 months, and I'm not going back to play the tourney in 2 months, maybe that helps us to pump the brakes a little bit and just kind of get comfy in the seat for the longer ride. That makes sense?
Yeah. I think we have to frame those expectations, especially for the length of time, because so many people buy into the BS of 3 weeks, 4 weeks, and you're back at it. we have to have that conversation. And I think underscore Toby should find a professional that can actually have that conversation and be honest, because it's a hard conversation to have with a lot of people. We can go into language and a whole bunch of other stuff now, but it's very important setting those expectations.
Definitely.
I think part of there's a lot of, like we said, there's a lot of factors that go into injuries, and that's why it's so hard to prevent or predict. And there's a lot of reasons for that too. I think that it's just hard to recreate game scenarios in clinic. I think it's hard to recreate the forces that go through your body in those controlled environments. And I think that athletes are really good, or our bodies in general are really good at stress shielding the affected area. And our eyeballs are not sensitive enough to pick up underlying deficits, and our testing really isn't that sensitive either. Like the hop testing for ACL is not a great correlate to quad index. So somebody can have, pass their hop testing with flying colors, and they could still have a major quad index deficit underlying. And if you don't test that, and we also know that a manual muscle test just ain't going to cut it. So I don't think that our testing is sensitive or rigorous enough and consistent enough through the process to pick up these deficits that could actually be risk factors that we could modify. And I think that we rely way too much on our eyeballs to predict whether somebody's fit to return to sport or not. And I was trying to look for the paper. It was a PT Inquest episode. I listened to it recently, but I skip around, so I couldn't find it. I don't know if it was a recent episode or not, but they had somebody on who was an ACL researcher, and they were looking at post-op ACL reconstruction, athletes with post-op ACL reconstruction, and they were watching their squats, and they had them on force plates, and they couldn't observe. So they were trying to see if you could observe deficits from side to side, or like some type of shift or something like that. And what they found was it was very difficult to pick up on the fact that like an athlete was shifting away. They were stress shielding their affected side, but you couldn't see it. Because typically we can see, like if it's a major hip shift, like, oh, they're obviously avoiding using that leg. Okay, let's intervene. But even if they look dead center, the body is just really, really, really good at being 3D and shielding that body part. And again, if we don't have sensitive enough testing, or we're not truly, our tests are not challenging the athlete, and we're just going by, the eye test, I think that's a part of the problem too. I think we send our athletes out when they're not quite ready. They're not prepared for game situations, and then there's no intermediate step. It's like if we clear them, or if the doc clears them, sport coach is like, all right, get in there. There's just like a disconnect. And that goes, that's athletic trainers are super important in that scenario, because they're kind of like there. Physical therapists are kind of on the fringes. We're in our clinics, we're kind of blinded, to that. So we send them off, and we just assume that sports med is taking care of them, and their sport coaches are going to be smart, and all those things. But I just think that's a big part of the issue too. Is we could do better.
Yeah, and the eye test is always difficult. The three of us right now primarily deal with, I don't want to call them simpler sports, but what I would consider sports of training. Weightlifting is a completely different monster, but compared to the multiple different angles that you have to create force on, say, a football field or a soccer field, powerlifting and weightlifting are a little bit simpler. How many times have you seen somebody who fails or misses or pulls a hamstring or something in what would be considered to them a routine squat? You can't see it. You can't. You don't even know. You just go, well, I don't know.
Yep.
Yeah. I think in our sport, training load is a whole lot easier to quantify.
Way easier.
And our sport is predictable, like you said. If somebody comes in, hey, what do you got today? What's practice today? Oh, it's a snatch and clean and jerk. Oh, it's a squat, bench, and deadlift. As a coach or healthcare provider, I know exactly what that is. That's easy. Football field, soccer field, basketball court. You're going to play basketball? Great. There's a million different scenarios that could happen. You're going to move your body in a million different ways. But, we'll go back to the ACL. It's like, hop testing doesn't mean anything. Well, they passed their hop testing, but I got them to a 90% quad index, so we're good. But, there's another layer. How about rate of force development? Because you could have somebody's quad index could be at 95%, but if it takes them twice as long to get to peak force, they might as well not have a quad. So it's like there's so many different factors that I don't think we test well enough for, and also that we don't have enough data on what is a prospective, threshold to get them to, or not. So it's just there's a lot to learn. I think we're going to get better, a whole lot better at reducing risk. I keep going back to the ACL scenarios because they're more straightforward than most things. If you talk about tendinopathy, I mean, hell,
it's fun stuff.
It's all retroactive at this point,
But at least we know that we're wrong right now.
Yeah, we're having the conversation.
At least we know there's a lot more to learn, and that's a big part of the step.